Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome to the Deep Dive. We're the show that takes a whole stack of sources, dives deep, and pulls out the key insights you need. Our goal, a shortcut really, to being genuinely well-informed. Today, we are plunging into ADHD, attention deficit hyperactivity disorder. It's fascinating, often misunderstood, and it's not just about kids having trouble sitting still, right?
Yeah.
It's a complex neurodevelopmental condition. Millions affected. Globally, it impacts, well, pretty much everything. Daily tasks, long-term life stuff. So we're going to unpack a big clinical review on ADHD, pull out the essentials so you can really understand what it's all about.
That's the plan. Yeah. We'll look at how our understanding has changed over time, from the very first descriptions right up to how we classify it now. We'll cover how common it is, the actual neurobiology, what's happening in the brain, how it gets diagnosed, the kinds of treatments that really help, multimodal approaches, and importantly, we'll get into some of the ongoing debates where the field is heading. Because the really big takeaway, I think, is how we've shifted from seeing it as just behavior to understanding its complex neurobiological roots. And that shift, it changes everything.
Okay, let's unpack that, starting right at the beginning. Where did this idea of ADHD even come from?
Well, it's not new. Not at all.
Right. People think it's a modern thing.
Yeah, but descriptions of behaviors that sound a lot like ADHD, they go back over 2 centuries in medical writings. And what's really striking, even back then, some observers kind of hinted, they sensed a link to the nervous system, maybe brain structure. They weren't blaming bad parenting or saying it was an intellectual issue. It's like they knew somehow it was biological.
Wow. So they had an intuition about it.
Seems like it. And then there was this huge moment in 1937. Almost accidental. An American doctor, Charles Bradley, he noticed that stimulant medication, this was unexpected, really improved behavior. Kids with what they called hyperkinetic disorder back then, they had less motor activity, did better in school.
Just from this medication?
Yeah. And this finding, it was purely empirical. They didn't fully grasp why it worked yet, but it basically laid the groundwork for the pharmacological treatments we rely on so heavily today, showed that meds could make a real difference.
That is fascinating. So the observation came way before the explanation.
Exactly.
And our understanding has kept evolving,
Right.
Especially through the DSM, the Diagnostic and Statistical Manual, like DSM-2 back in '68, called it hyperkinetic reaction of childhood, mostly focused on hyperactivity.
And the common belief was kids would just grow out of it.
Which we now know isn't true for many. But then DSM-3 in 1980, a big change, renamed Attention Deficit Disorder, ADD.
Yes, that was crucial. Finally acknowledging attention or inattention as central. Research was pointing that way.
And then another huge leap with DSM-5 in 2013.
Oh, absolutely. A massive paradigm shift. DSM-5 officially called ADHD a neurodevelopmental disorder, directly linking it to how the brain develops early on. That wasn't just tweaking a definition, it had real-world impact.
Real-world impact. How so? What changed?
Well, several key things in the criteria. The age symptoms had to show up. Pushed from before age 7 to before age 12. Big difference.
Okay. Catches more people, maybe.
Potentially, yeah. And the requirement shifted from needing clear evidence of impairment to the symptoms just being present and disruptive. The definition of clinically significant functional impairment became broader, too. And a really major one, autism spectrum disorder, ASD, was no longer an exclusion. You could be diagnosed with both.
Which happens quite often, right?
Clinicians were seeing it all the time. So, yeah. These DSM-5 changes, by framing ADHD as neurodevelopmental, it helped reduce stigma, boosted biological research, pushed for better interventions. It validated people's lived experience.
And you can see how those changes, like the later age onset, the broader impairment idea, how that might connect to seeing more diagnoses.
Exactly. It likely contributed to the increase we've seen, which isn't necessarily overdiagnosis. It could just be better recognition, especially in adults who were missed before.
Right. So better recognition leads us to prevalence. How many people are we actually talking about? What do the numbers look like?
They're pretty significant. For kids and teens, it's one of the most common mental disorders out there. A big 2015 meta-analysis estimated the global prevalence at 7.2%. That's roughly 129 million kids worldwide back in 2013.
Wow. 129 million.
And here in the U.S., it's about 10.5% of kids, so 6.5 million with an ADHD diagnosis.
And we mentioned it's not just kids. It often continues into adulthood.
Yeah, very often. Estimates suggest 40 to 60% of kids with ADHD still have symptoms as adults. An older screening from 2007 using DSM-IV criteria put average worldwide adult prevalence around 3.4%. But newer estimates from 2020, adjusting for global demographics, paint a potentially broader picture. They suggest about 2.6% of adults have persistent ADHD, meaning it started in childhood and continued. But maybe closer to 6.8% have symptomatic adult ADHD, meaning they have significant symptoms now, regardless of a childhood diagnosis.
Okay, wait. Persistent versus symptomatic. Why the different categories? Does that make it hard to count?
It definitely makes estimating adult prevalence tricky. Adult ADHD just hasn't had as much research focus historically. Plus, there aren't really well-established diagnostic criteria specifically for adults, so studies vary a lot, rely on clinical wisdom.
Ah, okay. So it's fuzzier for adults.
A bit, yeah. But that distinction, persistent versus symptomatic, it's important. It tells us many adults have real impairing symptoms now, even if they weren't diagnosed as kids. It points to a big problem of underrecognition, maybe underdiagnosis in adults.
With serious consequences, I imagine.
Oh, absolutely. Major functional impairments, risk for other mental health problems. It's a significant, often hidden issue.
Okay, that makes sense. So this history, the changing definitions, the sheer numbers, it all leads to the big question. What's the cause? What's actually driving ADHD?
Right. And it's definitely not just one thing. It's complex. A mix of genes and environment.
Genes play a big role, though,
Yeah.
right? I've heard it's highly heritable.
Incredibly so. Heritability estimates usually fall between 60% and 90%. That's really high for a complex disorder.
So if your parent or sibling has it.
Your risk is about 5 to 10 times higher than average.
Yeah.
But it's mostly polygenic, lots of genes involved, each with a small effect. Common genetic variants only explain about 22% of the heritability we see, so there's still a lot we don't know about the specific genetic architecture.
Okay, so genes load the gun, maybe. But what about the neurobiology? What's actually different in the brain?
Yeah, this is where the research gets really compelling. Brain imaging studies consistently show some differences. Certain areas might be slightly smaller on average in kids with ADHD. We're talking about the prefrontal cortex.
The brain's CEO, basically. Planning, focus.
Exactly. And the basal ganglia involved in things like motor control and reward. Also the cerebellum, corpus callosum. We also see evidence for delayed maturation of the cortex. The gray matter, the brain's processing tissue, seems to reach its peak thickness about 3 years later in ADHD, especially in those prefrontal areas.
3 years later, that sounds significant.
It suggests a difference in the developmental trajectory. And there's also evidence for reduced connectivity. White matter tracts, the brain's wiring, might be affected. Things like a smaller corpus callosum, which connects the two hemispheres. It could mean altered myelination, the insulation on the wires, affecting signal speed.
So, structure and connections. What about brain chemistry, neurotransmitters?
Ah, yes. That's a huge piece of the puzzle. Dysregulation of neurotransmitters, specifically noradrenaline or norepinephrine and dopamine, seems key. Dopamine is crucial for attention, motivation, reward. Noradrenaline for alertness, vigilance. Research often points to differences in the dopamine active transporter, the DAT.
The DAT. What does that do?
Think of it like a vacuum cleaner. It removes dopamine from the synapse, the gap between nerve cells, after a signal is sent. If the DAT is too active, or if there isn't enough dopamine released in the first place, you don't get enough dopamine signaling. That impacts focus, executive function.
And that connects directly to why the medications work.
Precisely. It's a beautiful link, actually. The main stimulant medications work on these systems. Methylphenidate, like Ritalin or Concerta, primarily blocks that DAT vacuum cleaner, so more dopamine stays in the synapse, boosting the signal.
Yeah.
Amphetamines, like Adderall or Vivance, do that too, but they also increase the release of dopamine and noradrenaline. Non-stimulants work differently. Atomoxetine boosts dopamine indirectly in the prefrontal cortex via noradrenaline pathways. Guanfacine targets specific adrenergic receptors to strengthen prefrontal networks involved in working memory.
It's amazing how the treatments map onto the suspected biology.
It really is.
And we shouldn't forget environmental factors entirely, right?
Yeah.
Things like exposure during pregnancy, maybe lead, nutrition, epigenetics.
Absolutely. They're part of the complex mix: maternal smoking or alcohol use, lead exposure, maybe certain nutritional factors. And epigenetics, how the environment can influence how genes are expressed. That's a really hot area of research now.
So putting it all together, it really reinforces this idea of ADHD as a biological condition, not a choice or a failing.
Exactly, which is so crucial for reducing stigma. And here's something fascinating. Even unaffected first-degree relatives, siblings, or parents without an ADHD diagnosis, they often show subtle deficits on cognitive tests. Things like working memory, processing speed. It shows how the genetic predisposition can manifest even below the diagnostic threshold.
Wow. So the biology is really there. Okay, let's shift to how this actually looks day to day. How does ADHD present, and how do clinicians diagnose it? Two main symptom groups, right? Inattention and hyperactivity impulsivity.
That's right. For inattention, think things like making careless mistakes, trouble sustaining focus on tasks or play, seems not to listen when spoken to directly. Difficulty following instructions, problems organizing tasks, avoids things requiring sustained mental effort, loses necessary items, easily distracted, forgetful in daily activities.
Okay, quite a list.
And hyperactivity.
Fidgeting, squirming, leaving your seat when staying seated is expected, running or climbing inappropriately. Inability to play quietly, often on the go, or acting as if driven by a motor, talking excessively.
And impulsivity.
Blurting out answers before questions are finished, difficulty waiting their turn, interrupting or intruding on others' conversations or games.
So to get a diagnosis, you need a certain number of these symptoms.
Yes, and it depends on age. For kids under 17, it's 6 or more symptoms from either the inattention list or the hyperactivity impulsivity list. For ages 17 and older, it's 5 or more symptoms.
And they have to cause problems, right? Not just be quirks.
Absolutely. The symptoms need to have started before age 12, be present in at least 2 settings like home and school or work and social life. They must clearly interfere with or reduce the quality of social, academic, or occupational functioning. And they can't be better explained by another mental disorder.
And there are different types.
Yes, based on the pattern of symptoms, predominantly inattentive presentation, predominantly hyperactive impulsive presentation, and combined presentation, which is the most common, where you meet criteria for both. There's also an unspecified category.
So how does a clinician actually arrive at that diagnosis? Is it just a checklist?
Oh, definitely not just a checklist. It should be a comprehensive process. Clinical interviews are key. Talking to the individual, parents, teachers, partners. But interviews alone, while sensitive, they pick up potential cases that aren't very specific. They might flag people without ADHD.
Okay, what else?
Behavior rating scales are standard tools. Questionnaires filled out by the person, parents, teachers. Again, useful, but also lack specificity on their own.
So interviews and scales aren't definitive.
Not in isolation. They
Right.
can over-identify. That's where objective testing can be helpful. Neuropsychological tests, cognitive tests, like continuous performance tests, CPTs. One example is the Quantified Behavior Test Plus, or QBTP plus TP.
What does that measure?
It directly measures attention, impulsivity, and even hyperactivity by tracking head movements while the person does a computer task. Studies show tests like this can differentiate ADHD with pretty good sensitivity, around 87%, and specificity around 85%. Much better specificity than interviews or rating scales alone.
So ideally, you'd combine all these things: interviews, scales, maybe objective testing.
Exactly. It's not a monolithic disorder. It presents differently. Symptoms overlap with other things. Accurate diagnosis is complex. That poor specificity of interviews and scales highlights the risk of misdiagnosis if you don't do a thorough job.
And yet, in practice, there seems to be a disconnect. You mentioned clinicians find it easier with kids.
Yeah, research shows that around 72% of clinicians say it's easier to diagnose children, and a concerning 75% rate the available diagnostic measures for adults as just poor or fair.
Wow, that's a huge gap.
It is, and it likely contributes to underdiagnosis, especially, as we said, in adults, but also in females and minority groups who might present differently or face other barriers.
Okay, that leads us neatly into comorbidity, the fact that ADHD often doesn't come alone. People frequently have other conditions too.
That's incredibly common, yes.
Yeah.
Comorbidity is more the rule than the exception.
What are the most frequent co-travelers with ADHD?
Substance use disorder, SUD, is actually the most frequent, followed by mood disorders, depression, bipolar disorder, anxiety disorders, and personality disorders.
And that must make diagnosis even harder, right?
Right.
Because symptoms can overlap so much.
Absolutely. Take depression, shared symptoms like trouble concentrating, low motivation, fatigue. It can be hard to tease apart. And we know people with ADHD have higher rates of depression, even increased suicide risk. Some shared brain pathways might be involved.
What about bipolar disorder? That overlap sounds particularly tricky.
It is. High rates of comorbidity going both ways. Bipolar patients often have ADHD, and ADHD patients have higher rates of bipolar. During a manic phase, you see restlessness, talkativeness, distractibility. Sounds a lot like ADHD hyperactivity impulsivity.
So how do you tell them apart?
Key differences are the distinct depressive episodes in bipolar and its generally episodic nature versus ADHD's more chronic, stable pattern. But having both is tough. ADHD comorbidity often means an earlier onset and tougher course for bipolar disorder.
And anxiety.
Also very common. Nearly 2/3 of studies show higher anxiety rates in ADHD folks. Again, shared brain regions like the prefrontal cortex might be involved. Plus, living with ADHD, maybe having more accidents or negative social experiences, could contribute to developing anxiety.
And substance use disorders, the most common. What's the link there?
It's complex. Possibly shared neurobiology like issues with dopamine pathways and reward processing, reduced frontal lobe executive functions. Childhood ADHD is definitely a significant risk factor for developing SUD later on. Self-medication might play a role too.
So these aren't just randomly occurring together. It sounds like there might be shared roots or one condition influencing the other.
That's exactly the thinking now. Shared pathways, maybe interacting developmental trajectories. It means you really can't just treat the ADHD in isolation.
Which really highlights the need for that thorough assessment you mentioned. Getting the diagnosis right is critical.
Critical, because misdiagnosis leads to the wrong treatment. Giving stimulants to someone with undiagnosed bipolar, for instance, could trigger or worsen mania. You need the full picture.
Okay, so assuming we have an accurate diagnosis, maybe including comorbidities, what does effective treatment look like? You mentioned multimodal.
Yes. It's rarely just one thing. The best evidence points towards integrated multimodal plans, combining medication with behavioral therapies and educational support.
So not just pills, not just therapy, but a combination.
Exactly. For many, especially kids and teens, research shows behavioral therapy plus stimulants is better than either one alone. It reflects that ADHD isn't just a chemical imbalance or just a behavioral issue. It needs that holistic approach.
Let's talk meds first. Psychostimulants are usually the first choice.
Generally, yes. Methylphenidate types like Ritalin, Concerta, and amphetamine types like Adderall, Vyvanse, they have the most robust evidence for efficacy. Decades of research.
But people worry about side effects, right?
Understandably. Common ones are things like decreased appetite that can be problematic, especially for kids trouble sleeping, sometimes irritability or moodiness, headaches, stomach aches.
But about more serious concerns. Heart issues, addiction, stunted growth.
Good questions. Stimulants can cause small increases in heart rate and blood pressure, so monitoring is important. But large studies in adults haven't found increased risk of serious heart events if treated appropriately. Effects on growth in kids seem minor and temporary, often catching up later. They rarely worsen high sex, might even help sometimes. And the addiction concern. Actually, appropriate stimulant treatment for ADHD does not seem to increase risk of later substance abuse and might even be protective, reduces the drive to self-medicate.
Okay, that's reassuring. What if stimulants aren't right for someone? Side effects too bad or they just don't work?
Then we have non-stimulant options. Atomoxetine, brand name Strattera, is one. It can be quite effective, sometimes good for co-occurring anxiety. It helps executive function. Downside is it takes several weeks to kick in fully, and it has that FDA black box warning about a rare risk of increased suicidal thoughts in kids-teens, so careful monitoring is needed.
Any others?
Alpha agonists like clonidine and guanfacine, often used as add-ons, may be particularly helpful for sleep problems or co-occurring tics. Main side effects tend to be sedation, maybe low blood pressure or heart rate.
So it's a balancing act. Finding the right med, right dose, managing side effects.
Always. It requires careful discussion, weighing risks and benefits, ongoing monitoring, and really open communication.
Okay, that's the medication side. What about the non-pharmacological approaches? Behavioral therapies.
Crucial part of the plan. For preschoolers, parent management training, PMT, is actually considered first line, even before meds sometimes.
Training the parents.
Yes. Teaching them skills for positive communication, effective discipline, setting up structure and routines, using reinforcement. It's very effective. PMT is also helpful for school-age kids and teens. For older kids, teens, and adults, cognitive behavioral therapy, CBT, is often used.
How does CBT help with ADHD?
It targets practical skills organization, time management, planning, but also emotional regulation, tackling negative thought patterns, managing anxiety or depression that often come alongside ADHD. It helps people identify thinking errors and engineer their environment to support focus and reduce distractions.
I've also heard about metacognitive therapy. Is that different from CBT?
It is distinct, yeah. MCT focuses less on the content of thoughts and more on how a person relates to their thoughts, changing the process of thinking. It aims to improve planning, time management, problem solving by addressing underlying patterns of thinking, like cognitive distortions or rigid thinking styles.
Interesting. And what about lifestyle stuff? Exercise, diet, mindfulness?
Growing interest there, definitely. Mindfulness meditation shows promise for improving mood, quality of life, maybe some aspects of attention. Physical activity and exercise are good for overall health, and some studies suggest benefits for ADHD symptoms too, though maybe less robust than meds or therapy. And there's even research on doses of nature finding that spending time in natural environments can temporarily enhance attention and focus.
It feels like the definition of treatment is broadening, moving beyond just the medical.
I think so. Supporting overall well-being is becoming recognized as a key part of managing a chronic condition like ADHD.
Speaking of chronic, ADHD isn't something you just cure, right? It has long-term impacts. What does that look like across a lifespan?
Yeah, it's recognized as chronic, often debilitating. Without effective management, the impacts are pervasive. We see significantly poorer self-esteem, like 57% lower in one study, and poorer social function, 73% lower, compared to people without ADHD.
Wow, that's huge.
It translates into real-world difficulties. Trouble with time management, organization leads to academic underachievement, lower grades, maybe not finishing school. As adults, those struggles often continue into higher education, employment, holding down jobs, advancing careers. Social functioning remains a challenge.
And the risks if it's undiagnosed or untreated in adulthood?
They're significant. Higher rates of secondary mental health issues, depression, anxiety, SUDs we talked about, higher rates of divorce, intimate partner violence, more traffic accidents, job instability, financial difficulties. It casts a long shadow.
Does treatment change that long-term picture?
This is a really important, maybe sobering point. Treatment absolutely helps with symptoms. Self-esteem improves dramatically, like 89% benefit. Social function gets better too, 77% benefit. But some long-term studies suggest that even with medication treatment started in childhood, outcomes like final educational attainment or employment status by age 30 might not be significantly different from untreated individuals.
Really? So meds help day to day, but maybe not the ultimate life trajectory?
It seems treatment is crucial for functioning and quality of life now, but it might not automatically fix those long-term outcomes. It suggests we need more than just meds. We need ongoing support, skills training, maybe accommodations, addressing systemic barriers. Treatment is vital, but expectations need to be realistic. It's not a magic bullet for everything.
What other factors influence how someone does long-term?
Early intervention makes a big difference. Getting support earlier improves quality of life, school performance, emotional well-being down the line. Comorbidity is huge. Having other conditions like conduct disorder or major depression alongside ADHD predicts a tougher course, more persistence of problems. Bipolar comorbidity really worsens the outlook. And then there's treatment adherence.
Ah, yes, sticking with the plan,
Yeah.
which you mentioned can be hard for adults.
Incredibly hard. Adherence rates can be shockingly low. One study found less than 12% of adults were still taking their meds correctly after just 3 months.
12%? Why so low?
Well, think about it. The core symptoms of ADHD itself, inattention, disorganization, impulsivity, forgetfulness, they directly interfere with the ability to manage a treatment regimen.
Oh, wow. Right. Remembering appointments, refilling prescriptions, taking pills on time.
Exactly. It creates this terrible negative feedback loop. The condition makes it hard to treat the condition. It's a massive barrier to good long-term outcomes.
That's a crucial insight. Okay, let's pivot towards the future. What's new and exciting in understanding and treating ADHD?
There's a lot happening, actually. On the diagnostic side, researchers are exploring potential biomarkers. Using things like functional MRI or diffusion tensor imaging, fancy brain scans, or EEG brainwave analysis. The hope is these could offer objective markers, maybe predict treatment response.
Biomarkers, like a blood test for ADHD.
Not quite that simple yet, but maybe objective measures to aid diagnosis or track progress. There's also focus on identifying risk markers really early, even in preschoolers, before symptoms fully emerge. And looking further out, maybe AI and machine learning could integrate lots of data, clinical info, imaging, genetics for faster, more accurate diagnoses. Some AI is already used in digital therapeutics to predict if someone might stop adhering to treatment.
And more research on adults, finally.
Yes, that's definitely ramping up, addressing that historical gap.
Okay, what about new treatment approaches? You mentioned digital therapeutics.
Right, DTX. This is a really interesting area. Using technology, often apps or even video games as interventions. The most well-known is probably EndeavorX. It's an FDA-authorized video game for kids 8-17 designed to improve attention through targeted cognitive challenges presented in a game format.
A video game as treatment. Does it work?
Right.
And do kids actually stick with it?
Studies show it can improve attention measures, and adherence seems much better than for medication in some studies, like 78% for the DTX versus maybe 52% for stimulants. The gamification, the reinforcement, automated reminders, it seems to overcome some of that adherence barrier we talked about. Side effects are usually minor, like frustration or headache sometimes.
Fascinating. What else is emerging? Neuromodulation.
Yeah, non-invasive brain stimulation techniques. Things like transcranial magnetic stimulation, TMS, uses magnetic pulses to stimulate specific brain areas. Early results for ADHD look promising, potentially improving core symptoms. Side effects usually mild, like temporary headache. More research needed, but it's promising.
TVCS.
Transcranial direct current stimulation uses weak electrical currents. Some studies show small but significant improvements in things like inhibitory control or working memory in ADHD. But the evidence base is still weaker for TDCS compared to TMS or DTX. Needs more rigorous study.
So these tech-based approaches sound cool, especially for engagement and adherence, but are they ready for prime time? Are those biomarkers useful in the clinic yet?
It's still early days for widespread clinical use, especially for biomarkers. While neuroimaging or EEG patterns might correlate with ADHD or predict treatment response in research settings, there are big hurdles. Lack of replication studies often use smaller specific groups, methodological issues, and practical things like cost and needing specialized expertise for brain scans. They're not routine diagnostic tools yet. Clinical decisions still overwhelmingly rely on that comprehensive clinical assessment, the interview, rating scales, history, observation.
Makes sense. Research potential is there, but not quite clinical reality yet.
Exactly. For DTX and neuromodulation, they're moving faster into clinical use, but we still need more long-term data and validation across diverse populations.
Okay. Now, no deep dive on ADHD is complete without tackling the controversies. And there's a big one. Overdiagnosis versus underdiagnosis.
Yeah.
How can both be problems?
It really is a paradox, isn't it? Concerns about overdiagnosis are fueled by that steep rise in diagnosis rates, especially in some countries. People worry about unnecessary medication, the potential anxiety from labeling kids, the financial costs.
What drives those concerns?
Maybe clinician biases, pressure from schools or parents, those changes in DSM criteria we discussed, making it easier to qualify. But at the same time, many experts argue ADHD is still massively underdiagnosed, particularly in adults. Estimates are that 75, even 80% of adults with ADHD might be undiagnosed.
75 to 80%.
Yeah, and that has those huge downstream consequences for mental health, functioning, quality of life.
So it's not just too many diagnoses, but maybe the wrong diagnoses or the right people being missed.
That's a great way to put it. It points to systemic issues. Maybe implicit biases in who gets diagnosed, lack of adequate training for clinicians, especially regarding adult or female presentations, lack of standardized, culturally sensitive tools. It's complex.
And you mentioned gender and racial disparities. Let's unpack that.
We definitely see them. Boys are diagnosed much more often than girls in childhood. Girls might be missed because their symptoms are less disruptive, maybe more inattentive. They might mask symptoms better. Clinicians might lack specific training on female presentations.
But that changes in adulthood.
It seems to.
Yeah.
Women are more likely to seek help later on, perhaps when juggling work and family exposes executive function challenges. So diagnosis rates tend to catch up or even surpass men's in adulthood.
And racial and ethnic minorities.
Clear disparities there, too. Black and Latino individuals, for example, are significantly less likely to get an ADHD diagnosis or treatment, even when they have similar symptom levels to white individuals. This points strongly towards underdiagnosis and undertreatment in these communities. Barriers like access to care, cultural stigma, potentially bias in assessment.
And the consequences of that underdiagnosis can be severe. You mentioned a pipeline.
Yes, the deeply concerning idea of a misdiagnosis to prison pipeline, where lack of adequate mental health support, including ADHD diagnosis and treatment, for minority youth contributes to difficulties in school, behavioral problems, and ultimately increases their risk of involvement with the juvenile and criminal justice systems where minorities are already disproportionately represented. It's a critical social justice issue.
That's incredibly sobering. So the need for better training, tools, outreach,
Right.
it's urgent.
Absolutely.
Yeah.
Combating stigma, dismantling biases, ensuring equitable access, it's vital.
Okay, one more area of controversy. the ethics of treatment, especially medication, and societal pressures.
Right. There are legitimate ethical debates. Concerns about potential overprescription, particularly when ADHD symptoms can overlap with typical, if challenging, childhood behavior. Questions about the long-term effects of stimulants on the developing brain. While short-term safety is well studied, what about effects into middle age or later life? We just don't have that data yet. Potential neuropsychiatric risks need ongoing monitoring.
And the role of pharmaceutical companies.
That's part of the conversation, too. Concerns about aggressive marketing potentially influencing prescribing practices, and a broader philosophical debate about the medicalization of childhood. Are we too quick to use medical solutions for behaviors that might have been managed differently in the past?
The social control argument. Using Ritalin to make kids easier to manage.
That concern is definitely out there. Worries about dampening kids' natural spiritedness, and the ethics of prescribing off-label, like for very young children under 6, where the evidence base is much thinner.
So this isn't just a medical issue, it's a societal one with real ethical weight.
Absolutely. It demands ongoing ethical scrutiny, transparent communication between doctors, patients, families, and a move towards integrated care that looks at the whole child, their development and well-being, not just symptom reduction.
Wow, okay. What a deep dive this has been. We've covered so much ground. From the unexpected history, the brain science, diagnosis, treatment, all the way these really complex controversies and ethical debates.
It really is a multifaceted condition. To sum up, ADHD is a complex neurodevelopmental disorder. Our understanding is constantly evolving, but the biological basis is strong. It has profound impacts across a person's life. Accurate diagnosis using multiple methods is key, especially for those often missed adults, women, minorities. And integrated multimodal treatment offers the best chance for improved outcomes.
So as we finish up, here's something provocative for you, our listeners, to think about. Considering everything we've discussed, the debates around diagnosis, the ethics of treatment, the persistent disparities, how do you think our society's view of ADHD might shift over the next decade? And what role do you see technology, like the DTCX we talked about, and maybe a growing understanding of neurodiversity itself playing in shaping that future? Lots to ponder there. Thank you so much for joining us for this deep dive into ADHD. We really encourage you to keep exploring, keep learning about this widespread, complex, and often misunderstood condition.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.